Good afternoon. Welcome to today's webinar. We're going to give everyone just a bit more time to join and then we'll begin. Welcome to today's webinar. We're going to go ahead and get started. My name is Carrie Rutia, and I'm an Oncology Outreach Coordinator with the Samaritan Cancer Resource Center. All right, so before we get started, let's go over a few virtual housekeeping items. Today's presentation is being recorded, and the recording will be available online at a later date. We'll be using the universal mute button, so please use the chat box up in the right-hand corner. If you have any questions, we will be monitoring this chat box throughout the presentation, and as time allows, we will answer questions at the conclusion of the presentation. Okay, so it's my pleasure to introduce our first guest speaker, Dr. Jessica Germino. Dr. Germino received her undergraduate degree from the University of Chicago and her medical degree from Washington University at St. Louis, Missouri. Following a residency in diagnostic radiology at the University of Washington in Seattle, Washington, she completed a fellowship in breast imaging at the University of Washington, Seattle Cancer Care Alliance. Dr. Germino is the Director of Breast and Women's Imaging at Corvallis Radiology and works with patients at Pacific Communities Hospital, North Lincoln Hospital, Lebanon Community Hospital, Good Samaritan Regional Medical Center, and the Samaritan Albany General Hospital. Her clinical interests center around access to mammography with the goal of increasing utilization of screening mammography in our communities and promoting early breast cancer detection. All right, so without further ado, welcome Dr. Germino.
Wonderful. Thank you very much for having me today. I'm glad to be here as we start Breast Cancer Awareness Month this October and to kick off our virtual series. I do not have any disclosures, as you can see on the slide, no conflicts of interest or relevant financial relationships. Okay, so today the main focus is what happens to a woman after she has a screening mammogram. What are the different paths that might occur? What next steps? What might we discuss with you if you're called back for additional mammographic views or a biopsy? To start just with definitions, screening mammogram is an X-ray test of the breast tissue performed to detect signs of breast cancer in women without any symptoms. The goal of mammography, screening mammography, is to detect breast cancer early. Since we started performing routine mammography a few decades ago, we have found 40% reduction in death or mortality from breast cancer in the United States. It should also be noted that screening mammography is not just for women with a family history of breast cancer, as 3 out of 4 women have no family history, are not considered high risk who receive a breast cancer diagnosis. And finally, women from age 40 to 49, a younger cohort of women, 1 in 6 breast cancers occur in women this age. When you come in for your screening mammogram, our goal is to get 2 views of each breast. As you can see, we compress from above and below to get 1 view, and at an angle along the side to get a 2nd view. Our goal is to try to include as much breast tissue as possible with a mammogram to help us detect breast cancer. If you have breast implants, we will do additional special views to try to increase the amount of breast tissue that we can see. So with screening mammogram here on the screen, you will see on the left some images from screening mammography where it says CC means our compression from above and below. We try to get so far back as to include your pec muscle, your pectoralis muscle, which is at the back of the breast. And you can see the pec muscle as this triangle of white on this other view. We're trying to include as much as we can so that we know we're including as much breast tissue in front of it on the mammogram. At Samaritan, we have 5 sites offering screening mammography. Each star indicates one of the sites where we perform this test. You can see in Lincoln City, Newport, Corvallis, Lebanon, and in North Albany. I'm very happy to say that at all of our sites, women can expect to have a 3D mammogram. The technical term for this is tomosynthesis. This is an example of the type of machine you will see when you come to mammography for your screening mammogram. Technologist stands here and looks at the image produced while you will be in compression in this machine here, getting images of your breast tissue. This mammogram is an example of 2D or digital mammography on the left. You see specks of white in a sea of black. That is, specks of white are breast tissue, the black is breast fat. You can't really see much suspicious or abnormal on the digital mammogram in this particular patient's case. But when we can use 3D mammogram or tomosynthesis, the circle here shows a suspicious area, a mass, and some twisted or distorted breast tissue. So 3D helps us see through some dense breast tissue to uncover an abnormality. After you have your screening mammogram, you will be notified of results by letter. There are 3 potential letters you would receive. Continue annual screening. So we'll see you next year. Your mammogram is normal. We may recommend, however, that you return for additional mammogram views or even a breast ultrasound because your screening mammogram has an area of question or concern. But what I do want you to know before your screening mammogram is the vast majority who receive a screening mammogram will just continue to annual screening. 90% have a normal mammogram and will not need to return for additional views. Now, if you do receive a letter asking you for additional mammogram or ultrasound, that's only about 10% or 10 out of every 100 who get a screening mammogram. 6 of those women, 6 out of that 10, will be told your mammogram is normal. We just needed to clarify an image on your mammogram. We're reassured and we'll see you next year. 2 of those women will be asked to return in 6 months to double check an area that we think is probably benign or not suspicious. So you may be told 2 out of 100 women, please return in 6 months, we'll reassess an area. And 2 out of 100 will be asked to have a needle biopsy to further evaluate a suspicious finding. This slide further details some of those numbers. It's based on a very, very large sample of screening mammograms. And what they outline in this slide is, in practice, how many women are called back and how many cancers do we detect with screening mammograms. One thing to note is this large database relies primarily on 2D or digital mammograms. Most of it is not, does not look at 3D mammogram results. So the percentage out of 100 women who would be asked to come back for additional mammograms in this large database is 11.6%. okay? And of 1,000 women, they'll detect 5.1 breast cancers, okay? So that's less than 1% will find a breast cancer. With 3D mammograms, though, our data that we have at this point indicates an increase in that cancer detection by 9.5%. So we know that we're finding more cancers with screening 3D mammograms than we previously have with 2D or digital mammography. If you get a letter asking you to come back for additional images, there are a few things your radiologist may be looking at. They may call you to further evaluate what we call an asymmetry or asymmetric breast tissue. Oftentimes, there's nothing wrong with the breast tissue or nothing abnormal. We just need to smooth out the breast tissue and make sure nothing is hiding. Make sure that that asymmetry is just superimposed breast tissue or an artifact. That's not always the case with asymmetries, though, and that is why we may ask you back to look further at an area of asymmetric breast tissue. We may evaluate what looks like a mass on ultrasound, something called calcifications, which look like tiny white dots on your mammogram, or distorted breast tissue. The terminology that we use is architectural distortion. When there is distorted breast tissue, it looks like you are there's a pinch in the breast tissue, it's tugged in. So for an asymmetry, like I mentioned previously, much of the time, this is an artifact on your screening mammogram or dense tissue piled on itself. We can clarify this by getting a few extra views, smoothing out the breast tissue, and sometimes performing an ultrasound to make sure that there's no suspicious lesion or other abnormality in that area. Now, if the asymmetry is persisting, it continues to be seen with those additional views, this could represent a new area of breast tissue development, a mass, or something called a developing asymmetry, which is a fairly technical term we use in mammography. Most commonly, like I said, we perform something called spot compression views. You'll come in and the mammography technologist will use a special paddle that's different than the type of paddles that we use to compress the breast for a screening mammogram. And what this does is it allows us to better smooth out one particular area of interest. We often will add ultrasound if you have dense breast tissue to double check that area and make sure there's nothing suspicious on either mammogram or ultrasound. If everything is reassuring, we'll have you come back next year for a regular screening mammogram. A mass is defined as a density on mammogram that has convex shape. Okay, so it bulges out. You can see a couple examples of masses here, and most of the time with a mass, if not all the time, we'll also use ultrasound to evaluate it. The reason is that mammogram cannot tell the difference between a cyst, which is a fluid-filled sac in the breast, which is benign and not worrisome, or a mass that is solid tissue. Here's an example of an ultrasound. Ultrasound here shows a dark oval. This is fluid. This tells us that this is a cyst. In this particular case, the cyst did have an area of solid tissue in it, so it was complicated, or it may even be a complex solid and cystic mass. But we can tell the difference by ultrasound, giving us more information about the screening abnormality and help us decide if we can leave alone, follow, or biopsy. So if you're asked to have an ultrasound after your additional mammographic views, that's very common, and it helps us problem solve and gather more information so that we can make a good decision regarding management. The special case that I was referring to before of a developing asymmetry is when you have a new density or white spot on mammogram that is new or increasing, more conspicuous over time. This is an image of one woman's mammogram from the medical literature that shows over time at the arrow an increasing white spot or developing asymmetry. Okay, and so these are called back for further evaluation because if detected on a screening mammogram, research shows that almost 13% of developing asymmetries are a breast cancer. That's not a high number, but it's high enough that we'll often recommend a biopsy to figure out what the developing asymmetry could represent. So if your radiologist uses the word developing asymmetry and recommends a biopsy, that is normal. Only about 13% of these are breast cancer, but we often will biopsy so that we know what's going on. Okay. If you're asked to come back after your screening mammogram to get more information about calcifications, that's also a very common reason. Many calcifications are benign or not cancerous. You will have special views that your technologist may call magnification views. And what they do is they zoom in on calcifications and they help us better visualize the shape, the distribution, or how these calcifications are seen throughout the breast tissue to determine if they are something that we can leave alone, benign, and so you can go back to getting a screening mammogram in a year, follow in 6 months with another mammogram, or biopsy under mammogram guidance. Here's an example of multiple calcifications that we may see that are typically benign, meaning we may leave alone or follow in 6 months. Clearly, calcifications, if we perform special views and identify that they're within the skin, can be left alone. Skin calcifications do not involve breast tissue and are benign. You can see something called milk of calcium. It looks like layers, crescent layers of white, like at the bottom of a teacup. That's fluid milk of calcium layering in the bottom of tiny cysts, and we can often figure that out just by mammogram. Multiple other types of calcifications may be seen that we can associate with a benign or a non-cancerous process. And as breast radiologists, we study these types of calcifications. The literature has looked at many of these and can help guide us as to whether or not your calcifications are something that we can just leave alone or follow. There are certain types of calcifications that have been identified and studied over time that we do consider suspicious. And oftentimes, these are the types that are recommended for a needle biopsy. It may be a combination of the shape or morphology or the distribution in the breast. And when your radiologist looks at your special mammogram views of calcifications, she or he will make a determination or decide with you if the calcification should be biopsied. As you can see in this image, there are descriptors associated with different calcifications. Amorphous, meaning no real shape, calcifications can be seen with a benign process, but also with a very early form of breast cancer called ductal carcinoma in situ. In fact, amorphous calcifications turn out to be a breast cancer about 1 out of 3 times, 27% of the time in some literature. More suspicious calcifications as we go along are seen in the bottom row. Fine linear branching, fine linear calcifications are the most suspicious, with almost 78% of these, almost 80% of these representing a breast cancer. Another finding on screening mammogram that we perform additional mammograms to assess, and often an ultrasound, is architectural distortion. This is the technical term we use in breast radiology to discuss distortion or a pinching in of normal breast tissue without a mass. So we may not see that solid ball of tissue, a mass with convex margins. We may just see pinching in at the center of distortion, making us wonder if there is something affecting the breast tissue. Architectural distortion is a finding that if it persists on your additional mammogram views, meaning that it is not an artifact or breast tissue superimposed or on top of itself, it's often recommended for biopsy. As a matter of practice, I tend to biopsy these if there's no history of surgery there, so it's not a surgical scar, and it persists. We may biopsy on mammogram if it's only seen on mammogram, but if we can find on ultrasound the area very well and see it well, we'll do it by ultrasound as well. You may be recommended for either type of biopsy when we see architectural distortion. As I've been talking about biopsy throughout this talk, what I'm referring to is needle biopsy done with the guidance of mammogram, ultrasound, some type of imaging, which I'll discuss later also includes breast MRI. This is a needle through the skin after it's been cleaned and numbed up. This is a pretty accurate, fast, and well-tolerated procedure that has over time replaced prior methods of breast surgical biopsy, and the benefits are lower cost and no need for general anesthesia. When a mammogram biopsy is recommended, you may hear the term stereotactic biopsy. What we're doing here is we're biopsying a finding, which could be asymmetric breast tissue, calcifications, architectural distortion, for example, that we best or only seen on mammogram. In our system, we perform these both at Valley Imaging in North Albany and in Corvallis. You'll see two pictures here just to help you visualize how we do the biopsy. This right here is called a prone biopsy unit. Prone means lying on your tummy. And as you can see, you're lying on your tummy, there's a hole in the table and your breast is held still in compression under the table so that the radiologist can access your breast tissue, take pictures. There's a mammogram machine associated with this biopsy machine, and hone in and identify the area that we find suspicious. This is a very well tolerated procedure. We only need to use numbing in the breast tissues, and afterward we'll place a small marker called a biopsy marker clip to show where we've done the biopsy. You may alternatively have a biopsy where you're sitting upright. This is the mammogram machine you may be used to encountering for your screening mammograms. As you can see, there's a needle attached to the paddle, and this is the detector where we can take a picture of a mammogram while holding the breast still and biopsy a tiny area of concern. Ultrasound guided biopsy is another way that we can assess an abnormality or an area of question in the breast that we see on ultrasound. With this type of biopsy, the radiologist is holding what's called an ultrasound probe. This gives us images of the breast tissue. And you can see this doctor has a screen behind her that shows breast tissue. So as she's scanning with this ultrasound probe, she finds the area that we would like to biopsy, and she'll watch live as she biopsies this spot with a needle. This is also a very well tolerated procedure, just done with local numbing medicine in the skin and in the breast tissue. After your biopsy, in our system, you will receive a call from the breast imaging department or radiology department with your results. They will explain the pathology results or the biopsy results to you. I think of biopsy results falling in one of three categories. Biopsy results may be benign. They make sense with the imaging findings. It's something that we can leave alone, and your radiologist may either recommend returning to regular screening or may do a follow-up just to double check the area in 6 months. There are some pathology results that are benign, but don't be surprised if your radiologist tells you that they'd still like you to see a surgeon to discuss removing this finding. Some are considered higher risk, meaning that if you remove them, a small breast cancer is associated with this particular finding. And so I view it as kind of in the middle of a benign and cancer pathology result, in that we are asking you to do something else. We're asking you to see a surgeon to remove it entirely from your breast so that a pathologist can look at it in its entirety and make sure that there's no surprise, no evidence of cancer there. And then finally, a breast cancer is the final possibility for biopsy. If additional steps are needed, for instance, if this is something that's benign, but we recommend having it removed, we'll tell you that you'll need to see a surgeon and your doctor can help you get that referral. If it's a breast cancer, we'll go over what the next steps are so that you're not left wondering what to do next. If it's a breast cancer, we'll tell you about the types of providers that you would typically need to see, including surgery and medical oncology. And then we'll also get you in touch with a navigator, a nurse navigator, who will talk to you more about your cancer diagnosis, answer questions, and help you get those referrals. Okay. What I'm letting you know essentially is that after the biopsy, you will hear from us and we'll give you instructions if any are needed, go over results and answer your questions so that you leave our conversation knowing what next steps, if any, are needed. After screening mammogram and additional mammographic views, and sometimes biopsy, your breast radiologist may recommend additional or advanced imaging in the form of a breast MRI. We sometimes recommend this after needle biopsy shows cancer, if we think that an MRI will better define what this cancer looks like before you go to surgery. And it is another means of screening your breasts for other abnormalities. It can provide more information than mammogram or ultrasound alone. For breast MRI, if you've never had an MRI, you're in a tube that does not use radiation, but actually a very large magnet to get information from the soft tissues or the body tissues, in your case, particularly the breast. You're lying on your tummy for this because that allows the breast tissue to be positioned in a way that it's not folded on itself and is extended, allowing us to better evaluate where abnormalities could be in the breast tissue. You'll see these 6 pictures in the black box. This just provides an example to show you the difference in appearance of an MRI compared to the mammogram and ultrasound pictures I showed you before. We are able to look at the breast and look at tissues in many different ways that allows us to hone in on areas that take up extra contrast or areas that take up extra water. And it helps us define if there are any other suspicious areas that might need investigation before your next steps in either breast cancer or another breast condition. When we perform a breast MRI, it's been found that an unsuspected or additional breast cancer is found in approximately 16 women in the same breast where they have the breast cancer. So for example, in this person, they had a breast cancer near the front of your breast. This is the right breast that we see on the left hand of the screen. The way we look at the MRI is this, as if you were lying on your back and your nose is pointing to the ceiling. So the nipples would be toward the top of the black box. The bright spots in this case are masses. And in this particular case, the brightest masses are breast cancers. Additional breast cancer is found in the breast where one was identified on mammogram and ultrasound, and MRI detected an unsuspected or additional breast cancer in the same breast. We've also found in literature and research that 4 to 5% of women will have a surprise or unsuspected breast cancer in the other breast, or the contralateral breast. As you can see, the brightest white spot in the other breast, the left breast, representing an additional or unsuspected cancer. Just like we can biopsy with mammogram and ultrasound, we can also biopsy by MRI if we cannot identify a suspicious area on ultrasound to biopsy. We can do it directly by MRI. And how we do this is we use a grid against the skin, which is this rectangle with tiny squares in it. This maps out the breast tissue like coordinates on a map, X, Y, and Z. And we just map out the breast tissue and are able to hone in on the area of interest by mapping out your breast tissue. So it's also possible, although less common, to have a biopsy using breast MRI. If you're recommended for breast MRI, other indications that you may hear about are for those women who are at an increased lifetime risk of breast cancer, which we consider greater than 20% lifetime risk by the American Cancer Society, as an additional way to do screening. So MRI as a supplement or in addition to screening mammogram may be recommended if you are considered at an elevated or high lifetime risk of breast cancer. Sometimes breast cancer is only found in your underarm lymph nodes. This is rare, but called occult breast cancer, and breast MRI can be used to look for the breast cancer within the breast tissue not seen on a mammogram or ultrasound. If you have silicone breast implants, you may, every once in a while, have screening with breast MRI to assess your implant integrity to determine if they are intact or ruptured. There are other indications for breast MRI as well, but these are some of the more common ones. As I previously explained, if a breast cancer is found by renal biopsy, you will have the radiologist call you and he or she will go over next steps. A nurse navigator with Samaritan will also be in touch to help you with questions and help with arranging appointments and referrals to cancer specialists. As I wrap up my segment, my talk with you, I just want to point out one thing. The focus of this talk has been, what happens if my screening mammogram is normal? What next? I just wanted to make a clarification that screening mammograms are for women without breast concerns, so no symptoms. If you have a symptom, a concern, a worry about your breast, some of those include lumps, pain, nipple, skin changes, nipple discharge, please make sure you're in touch with your healthcare provider because we perform special types of mammograms if you have symptoms, and oftentimes we'll want to follow that mammogram with an ultrasound. Oftentimes after you have your diagnostic mammogram, which is the type of mammogram if you have symptoms, the radiologist will go over the results with you that day. And so it's just important to make sure when you schedule your mammogram that we know the type of mammogram you need, a screening mammogram or diagnostic mammogram for symptoms. That concludes my portion of this talk. I'm going to pass this along now to Erin Dunn.
Thank you so much, Dr. Germino. That was so informative. So my name is Erin Dunn, and I'm the Samaritan Oncology Outreach Program Coordinator. I'm going to talk very briefly about breast health resources, so where you can get your mammograms. Screenwise is a program that is through the Oregon Health Authority. Screenwise partners with a network of healthcare providers throughout the state to provide breast, cervical cancer screenings to eligible patients. The providers in their program include primary care providers, surgeons, imaging and facilities, labs, and others. You can see more information about Screenwise at their website or by calling. We also have Samaritan Patient Financial Assistance. Anyone is welcome to apply for patient financial assistance. The program may help pay for your total bill or provide discounts to patients who meet the eligible criteria. To learn more about patient financial assistance through Samaritan, you can check out their website or call the 1-800 number. Patients who have been approved for Samaritan Patient Financial Assistance and have been referred to Corvallis Radiology from a Samaritan physician may be eligible for help with their mammogram bill. They can find out how much would be covered beforehand, and when that bill comes in, they take that bill to their patient financial advocate for processing. The patient financial advocates are at each one of our Samaritan sites. Again, this is the contact information for Samaritan Patient Financial Assistance and Screenwise. If you are seeking to establish care for a mammogram referral, you can visit our Samaritan Find a Doc website or call the 1-800 number. If you are needing in more urgently, you are welcome to call the Samaritan Cancer Resource Center and ask us about our mammogram referral program. Screenwise also has a list on their website of participating providers, and you can also check with your local health department. We at the Samaritan Cancer Resource Center are here for you. We provide a variety of different programs and resources. Please do not hesitate to give us a call with any questions or concerns. Thank you so much for your time today. Our next topic in this series will be next Wednesday with oncology dietitian Athena Noffendiger, speaking on hot nutrition topics. Thank you so much to Dr. Germino for her valuable information today. Now I'm going to pass it back to Kara so she can open it up for questions in the comment box if we have any.
All right, thank you so much, Dr. Germino and Aaron, for your presentations today. They're both very informative. It looks like we have received one question so far in the chat box. I'm going to go ahead and read that question right now. So the question says, can you please explain what dense breast tissue means? Does this make a mammogram more difficult to read?
Oh, what a great question. I'm going to go back in my presentation just to give an example of breast tissue for you for this question. Dense breast tissue, it is part of Oregon law and many states' law that we notify you in your mammogram screening letter if you have what's called dense breast tissue. Dense breast tissue, that term really falls two categories that we use in breast imaging to describe the breast composition or density. In this mammogram that you see here, I would call this breast tissue heterogeneously dense. Okay, when breast tissue may obscure or hide a mass or other findings, and there's really more breast tissue than fat, you may be considered having dense breast tissue. If you read your mammogram report, the two categories how we describe breast tissue in a report that are considered dense and trigger notification of your breast density status are heterogeneously dense breast tissue or extremely dense. If you have fatty breast tissue, then your breast tissue is predominantly fat, which is darker on mammograms. And you may have scattered breast tissue as well, just scattered fibroglandular tissue. This mammogram shows scattered dots of fibroglandular tissue on mammogram here or there. And this mammogram is what I would call extremely dense. So we see a whole spectrum of density. If you have dense tissue, you're either extremely dense, where you see all this white on the mammogram representing dense breast tissue, or heterogeneously dense breast tissue, such as this, with this white on the mammogram being breast tissue. Why that's important is that mammogram is less sensitive, or it may not see things as well if the white density is blocking, say, development of a mass or asymmetric breast tissue. That's why we let you know that. When we transition to 3D mammography, one of the benefits of 3D mammography is that we believe it can help us see through this density a little bit better. We can scroll through live looking at the mammogram images, and sometimes it helps us pick out a new dense area, mass, or architectural distortion in the breast tissue that would otherwise not be seen on 2D or 3D mammography. So that is what dense breast tissue means. You'll be notified in your letter explaining if you have dense breast tissue. And part of that rationale nationally is also to let women know that if they fall into certain risk categories, they could consider supplemental or additional screening with breast MRI if you're high risk for breast cancer, over 20% lifetime risk, or if you opted, you could have supplemental screening with whole breast ultrasound, which is a discussion that you should probably have with your radiologist and primary care physician to understand if that's the right choice for you.
All right, thank you for that great explanation about dense breast tissue. It looks like we haven't received any more questions so far. Let's give about another minute or so before we proceed to the end of the webinar. All right, so we did have two more questions come in. So the first question reads, besides for family history, what puts a woman at high risk for breast cancer?
Okay, that's a great question. And I'll interpret that as family history and known genetic risk factors, predispositions. That's a long subject that's still, there's probably a pretty long answer to that. There are a lot of factors that have been studied that may increase your risk of breast cancer. And there's a long list. I don't know that I can go through all of them. Some major ones are if you had a type of lymphoma when you're younger and you had radiation treatment for lymphoma to your chest at a young age, we know that those women are at increased risk of breast cancer. There's no family history there, but there's an exposure, okay? Some women have had biopsies, breast biopsies in the past where they had atypical cells found. And when we see certain types of atypia, as we call it, you may be at increased risk for breast cancer as well. Having dense breast tissue puts you at a slightly increased risk, okay? And many, many other things in your life may contribute variable degrees of risk. If you think, the most important thing I would say here in this question is if you think you have an increased risk of breast cancer or are concerned about it, the best thing to do would be to talk to the provider that you see for breast health, whether that's your primary care provider or another clinician. There are tools out there that can be utilized to estimate your lifetime risk of breast cancer. And what they do is your provider can enter in information if they think that you are considered high risk, and based on large databases and research, come up with an estimated risk of breast cancer. That's what is often used when determining if a woman is at high risk for breast cancer and would benefit from additional screening, such as MRI. Family history often does play a history in these situations, okay? But, you know, there are other things that can increase your risk of breast cancer. And so I would recommend, if you are concerned at all, or you have information that you want to share with your provider, that may help them assess your lifetime risk or help assess the best cancer screening program for you, that you just chat with them and go over your questions and specific concerns so that an individual assessment or evaluation can be made.
Thank you so much, Dr. Germino. Well, it looks like that will wrap up the Q&A section of today's webinar. We will shortly be emailing out a link to an evaluation. We would please ask that everyone takes a brief moment to complete the evaluation. The evaluation helps to provide us feedback for future events. If anyone has any remaining questions, please feel free to reach out to us at cancerresourcecenter@samhealth.org. We'll be happy to assist and answer any questions. And once again, I'd like to give a huge thank you to Dr. Germino, Erin, and for everyone that was able to attend today. We hope to see you again at our upcoming webinars. Have a great rest of your afternoon.